welcome to the show, where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have James Maskell. He is a healthcare executive, and he wrote the Kevin MD article, Get Familiar with the 2022 Coding Changes. James, welcome to the show.
Hey, great to be here with you, Kevin. Thanks for having me.
So we'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Yeah, so look, I grew up in England. I did healthcare economics at university, and in my studies saw that whether I was looking at the future of England or the US, in both countries with very different medical systems, we were going to head over a cliff in my lifetime where essentially both countries would run out of money servicing chronic disease, essentially. You know, the cost was exploding at an exponential rate, and it was chronic disease driving it. And at the time, I had a job as an investment banker, and I quit really to dive in. And this is 17 years ago, to the front lines of healthcare in America, to really understand the root causes of chronic illness and to try and sort of find a path towards solving that key problem.
All right. From your view as an economist, what would you say are some of the major drivers that are causing our healthcare system to consume almost 20% of our GDP?
Well, I mean, the long and the short of it is that if the majority of people have a chronic illness that is then medicated for the rest of their lives, you can see that, each one person's own cost explosion becomes a whole society's cost explosion. Mm-hmm. And the numbers on chronic illness, keep getting worse, even though lots of effort is being put into kind of understanding what it is. And, the first job that I had in America, I actually saw people with chronic illness reverse a chronic illness, right? Go from, having an autoimmune disease, having type 2 diabetes, and not in a week, but in over 3 months, 6 months, 9 months, 12 months, with a new sort of empowered operating system for medicine where the patient was participating in their care. I saw people, reverse their chronic illness. And that was the first sort of step on the journey. So, I think, what exists at a society level is just made up of what's happening at a personal level. And, you can imagine, I'm sure many of your listeners and doctors understand that if someone's diagnosed with an autoimmune disease, if they take Humira in, 3 years, they're taking 5 drugs and their care costs $100,000 a year. And if that keeps getting worse, it'll cost $250,000 a year. And you get enough of those people stacked on top of each other and you have a cost explosion.
All right, let's transition into Kevin MD article that you wrote. It's titled, Get Familiar with the 2022 Coding Changes. And we do have an audience of clinicians here who certainly are very interested in a lot of the coding changes. And as you know, a lot of clinicians, we don't have a lot of formal training when it comes to coding. So sometimes these changes are a little bit arcane to us, but it really makes a huge difference in our bottom line. So for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, so look, I mean, I've been passionate for the last 17 years about what I would call the evolution of medicine, right? How does medicine now adapt to these chronic conditions? When the medical system that we have was really formed and organized, it was really built around acute illness. And now we have a lot of chronic illness, and the etiology and the way that those diseases come about and expand and progress is very different. And so, for the last 16 years, I've been, helping doctors think through how do you reorganize your practice around some of these chronic conditions? How do you think about technology? How do you think about workflow? How do you think about different personnel in the office? Does it make sense to have nutritionists and health coaches and other people that are going to really help the patient participate in their care and make the lifestyle changes that ultimately, are the root cause of the vast majority of these chronic illnesses, right? So I've been doing that for a long time. And mainly where I've been doing that is in the sort of cash pay realm with direct primary care and, models that have allowed doctors to sort of exit the system. In the last few years, I've just become really passionate about solving the system itself, right? To actually change the system itself rather than playing on the edges with cash medicine, which is never really going to get to the people who need it the most. Medicare, Medicaid, commercial insurance, those are the people that we need to get to. So that's been tricky because one of the things that's really held back that evolution has been a huge friction point, has been the coding changes. Look, if you have to see people in a 5-minute visit and then you don't see them again for 3 months, very difficult to enact that kind of empowerment onto the patient in that structure. So when the 2021 coding changes came around, it was the most significant change in coding in history, in 30 years anyway. And there were some of those coding changes that I saw that thought, hang on a minute, if you were really paying attention and you were running your practice and really thinking through your product and service mix, there were some, opportunities to actually start to really reorganize your practice around the idea of reversing chronic illness. And so, over the 2 articles that I wrote recently at Kevin MD, I tried to, share with doctors what those openings were and how they could take advantage of it, to build models that not only would help empower patients towards better health, but would also be, helpful for the bottom line of these practices.
So let's go into a little more detail. What would you say are the top coding changes? And then you could follow that with what are some of the opportunities that these specific coding changes would bring?
Yeah, so some of the big coding changes, one is when you're dealing with complex chronic illness, a lot of times doctors wouldn't get paid for the effort that they would put in to really understand the case before the patient walked in, and then the case organization and collaboration after they left. And so, the sort of time-based coding and being able to count time that wasn't necessarily patient-facing, but was maybe being other members of your staff, that is a significant shift, right? If you're dealing, the more complex illness that you have, the more time that it takes to really understand the root cause. So that was a significant shift. There were significant shifts around how to use health coaches in the practice. So, chronic care management codes were established. And then actually in 2022, the reimbursement of those codes for doctor prescribed coaching was a big deal. And, there's this sort of pot of gold at the end of the rainbow for doctors, which is remote patient monitoring. And I think, all doctors love the idea of just understanding where their patients are, having a lot more dynamic data about where their health is trending, catching things early. But the operational lift to execute any of those things is tricky. To get remote patient monitoring up in your practice, can be tricky. And so, but I think there are like sort of openings in some of those areas where you say, okay, I can at least envision that if all my patients, if we had some way of understanding where their health was happening in real time, if we had someone running that who had, who was sort of at a lower cost and could get reimbursed for sort of monitoring that and then helping patients improve on those numbers, that would be, that would be really valuable. But the one area where I think there's the most opportunity right now in medicine is around group medicine. And I've been passionate about group medicine, and I actually wrote my second book, The Community Cure, on group medicine, because there's so much synergy that happens. And when you put patients of like diagnoses together and take them through a combination of learning, accountability, mentorship, and support. I mean, that's how they do it in Alcoholics Anonymous, right? That's how we reverse alcoholism, is we give them mentorship, support, and accountability. And one of the things that, that I worked out early on after these coding changes was that there's a real opportunity for essentially virtual lifestyle medicine groups inside medicine today. And that's what I've been working with physicians, is to make it really easy to implement those kind of groups. They're profitable, they're effective. And for chronic conditions where lifestyle is a component, a 6-month episode of care where groups of patients come together to start to implement healthy behaviors, all supported by health coaches, is, a new opportunity for doctors that care about chronic disease reversal.
So give us a story or a case study of exactly how that would work. So let's say, I am a primary care physician, but let's say I owned a small practice and I wanted to institute this group coaching model that you're describing. So tell me a story of how exactly that would look like, and how would that be billed and coded for?
Yeah, so I'll give you an example actually just right down the road here, because it was the first clinic that we worked with. So yeah, primary care clinic, 1 MD, 3 PAs, all trained in lifestyle and functional medicine, but again, doing very like one-on-one appointments, and finding it difficult to help people actually make the behavior changes. Like, they can come up with a great protocol, but what percentage of people are actually executing that in the field? And, because of the pandemic and just because of the state of American life, Kevin, I mean, most patients are overwhelmed with life generally. And so, to have a structure for that. So I went to that doctor and I said, look, what if we could come up with a partnership where you do what you're good at? You have the doctors, you have the insurance contracts, you have the patient base. And why don't we, and I'll take care of, we'll deliver all aspects of the group. So ultimately, we'll take care of not just hiring the coaches, training the coaches, delivering the curriculum, running the technology, but also the sort of annoying, boring parts that get in the way of running groups, like, like customer service, tech support, and those kind of things. So we ran a pilot. They recruited 65 of their patients. We put them in 4 groups of about 16. And over the next, 3 months, we took them through a curriculum that was based in Zoom. There was an opportunity for them to communicate in a sort of a HIPAA compliant like Facebook group in between the sessions. We started to see, some people are very good at making friends very quickly. And there was a huge loneliness factor, which is out there, which is really a big driver of all chronic illness too. But slowly you start to see these relationships, are created. You start to see people like getting it, they calm down, the nervous system calms down, they're feeling better. Some of the early signals that we saw was like anxiety, falling away, because people had now a safe space where they could like talk about what it's like to have a chronic illness, and saw that the coach has had a chronic illness and reversed their own chronic illness, and speak to the other people in the group. And then for the second half of the group, you really start to see real friendships emerging, real new behaviors emerging. And at the end of that 3-month episode of care, the outcomes that we were measuring on Promise, where more than 2/3 of the people who had high anxiety reduce anxiety, depression, fatigue, pain. It was a full spectrum biopsychosocial intervention, right? You have the social aspect, and they're creating new friends. There's psychological aspect because they're learning to meditate. They're learning to do box breathing. They're learning to take care of their stress and think about their disease in a new way, and really shifting from victim to hero, of their own journey. And then there's biological pieces too, because we're changing their diet and, taking out some of the inflammatory foods, and people supporting to do it. So, a 3-month biopsychosocial intervention led to significant improvements in these patient-reported outcome measures. Those were like cross-validated in many of those cases with lab data that the clinic was doing. And that was the beginning of this journey to think, okay, well, if this could work with one, in the last year, we've seen rheumatologists, pain doctors, gastroenterologists, any doctor that knows that the conditions that they're seeing are being either created or exacerbated by lifestyle have sort of, come along, and we've had a fun time executing those same kind of groups in partnership. And the cool thing about what's possible now, Kevin, is because of the telemedicine changes, the patient doesn't even necessarily know that this is like another company. It's really viewed as like an extension of the care of the clinician. And that's, helping to maintain a relationship with the clinic and to make the care profitable for the clinic.
And in terms of billing, is group coaching, like the scenario to describe, is it accepted and being able to be billed by most private insurers in addition to Medicare?
Well, the secret is that group coaching is, but the way that we've organized the groups, and this took a little bit of like finagling with the rules, is it actually mirrors what the AFP was recommending for group visits pre-COVID, which is essentially not to bill it as group coaching, to bill it as individual visits. And the way that we have it set up is that the provider sits in the Zoom breakout room and takes patients one by one into the Zoom breakout room to fulfill the criteria for what we call medical decision making. And that was actually one of the big changes in the coding, is that forever, you would have to determine whether it was a 212, 213, 214, 215 by severity or by how much face-to-face time you had with the patients. one of the big shifts was medical decision making. And so if you can get into it with patients in the breakout room, talk about their medication, talk about how their disease is either progressing or regressing or reversing, ideally, then the coach can just be in the main room of the Zoom and the provider can be in the breakout room. And that's just some of the sort of innovation that we've created in the last year to try and think about how to use these very familiar digital tools in a way that could, really make it easy for doctors to do this and to take the operational risk off their shoulders. I mean, if there's one thing I've learned in 17 years is that doctors just want to do the basics of, seeing patients and they really want to help. And, a lot of times if new ideas come with a lot of operational risk, they don't get executed or they don't get executed well. And that's not good for the patient. It's not good for the clinic. So we've looked to take as much of that off the shoulders of the clinicians so they can just focus on doing what they're best at.
We're talking to James Maskell. He's a healthcare executive. He wrote the Kevin MD article, Get Familiar with the 2022 Coding Changes. James, in addition to the group coaching model that you described, what are some other low-hanging fruit that physician practices can take advantage of based on these recent coding changes?
Yeah, look, I think the chronic care management codes in 2022 went up by over 50%, while E&M visits went down. So I think, what does that tell you? Someone somewhere is looking at all this and saying, wow, these people who are billing these codes are getting increases in health, in their community, and their outcomes are better. So let's reward that. And so, ultimately, if you look at codes like 99439, 99490, these are codes that have, the amount that they're paid has gone up for 2022, but ultimately this is doctor prescribed coaching. Again, so, that I think, if you look at all across the board, coaching is coming into medicine and we're looking at ways to do that. And not only is that code payable, but certainly remote patient monitoring is best done by a coach as well. So I think the big news is it's now profitable to deliver coaching inside your practice. Most patients with a lifestyle-driven chronic illness need some form of coaching to sort of nudge behaviors in a more healthy direction. One-on-one coaching is cool. Group coaching is much cooler. And I think that's a sort of a trend for 2022 and probably, for the future, because if someone on high at CMS is seeing that and making those changes to the code, they obviously see, okay, this is, a behavior that we want to nudge forward in physicians and practices.
And my final question, what are some of your take-home messages that you want to leave with the Kevin MD audience?
For a physician entrepreneur, this is a very exciting time to be alive. COVID has shown us that we do a horrible job of creating resilient humans, and coding changes are shifting to be able to make that a reality for your practice. And ultimately, there are people like myself out there that are trying to make it as easy as possible for physicians, physician entrepreneurs, and even health systems to take advantage of this and take us towards a more sustainable, healthful health system.
James, thank you so much for sharing your time and insight. And thanks again for being on the show.
All right. Thanks, Kevin.